Hello everyone, I hope you all are doing well. Today I am going to start with second part of shaping and cleaning of the radicular space. I am going to start with working length measurement. Working length measurement is defined as the distance from a coronal reference point to the reference at which canal preparation and obturation should terminate. Working length determination is not a separate procedure but first and most important aspect of cleaning and shaping of root canal. It is one of the most important steps have overall outcome of endodontic treatment. Inaccurate determination of working length is due to underestimation. If greater than 2 mm short of the radiograph apex, which resulted lower success rate. If under preparation, that means incomplete instrumentation under filling with apical circulation, latch formation leads to discomfort and pain. Overestimate, it means over preparation. We will have apical perforation, overfilling and post operating pain. Obturation beyond the apex, delayed healing and poor prognosis. Best outcome if 0 to 1 mm short of the radiographic apex. Here we said working length is correctly determined and filling is inadequate. Theoretically, the canal preparation should extend apically to the cemento-dentinal junction. This junction is located at near the greatest constriction, that is minor diameter of the apical foramen. The cemento-dentinal junction doesn't always coincide with apical constriction and is located 0.5 to 0.75 mm short of the anatomical apex. Thus, it is clinically recommended to terminate instrumentation and obturation within 0.5 to 1 mm short of the radiographic apex. Let's discuss some terminologies. Anatomical apex. It is defined as a tip or end of the root determined morphologically. Radiographic apex. It is defined as a tip or end of the root determined radiographically. Apical foramen, which is major diameter, it is the main apical opening of the root canal. It is frequently eccentrically located away from the anatomical or radiographic apex. Apical constriction, that is minor diameter, it is the apical portion of the root canal having the narrowest diameter. Cemento-dentinal junction, it is a region where the dentin and cemented united. Franklin S. Wien, a great deal of skill is required to determine working length using methods that are accurate and practical. Case of incisal edge fracture, caries, then flatten the teeth and use it as a reference point. In case of posterior teeth cusp tip, but use flat surface. In case of molar, avoid enamel undermined sloping surfaces. Defective restoration, because in multiple sitting, if we leave thin enamel, defective restoration, next time patient came, then again you have to recalculate reference point. What are the complexities in the apical third? Anatomic apex, morphological tip of the root that can be seen only after extracting the tooth. In radiographic apex, which is visible only on radiograph, but anatomic and radiographic apices do not coincide. There are some practical difficulties to locate apical foramen. As long as canal exit on mesial or distal direction, it can seen only on radiograph, whereas it exit into buccal or lingual direction. It can't seen on radiograph. You may end up over instrumenting. Cemento-dentinal junction, it is a zone where pulp meets Periodontal ligament. Level of cemento-dentinal junction may not be uniform. It can be 3 mm higher on first wall of the root canal. It is not practically useful landmark. What we do? According to Cutler's study, he described the apical anatomy or the anatomy in the apical third of the root as resembling that of the morning glory flower. He concluded that it doesn't taper to the point and terminate on the surface of the root. It is the narrowest part, which he called minor diameter, is slightly inside root. And from that point it flares like flower to exceed the major apical diameter on surface of the root. Apical foramen major diameter lies entirely in cementum. It was shown that in less than 50% of cases it coincides with anatomic apex. It can exit 0.2 to 3.8 mm short of the anatomic apex. So the apical foramen is neither at radiographic apex nor at the anatomic apex. Apical constriction, it is the narrowest part of the root canal. We all do our preparation to this point. This results in smallest wound site and optimal healing. Logically, the preferred apical limit for working length and obturation. It is considered to be 0.5 to 1 mm short of the radiographic apex but vary up to 4 mm. It marks end of the pulp space and beginning of the periapical tissue. Recommendation for apical limits: first, radiographic apex as apical limit. Second, up to predetermined distance short of the radiographic apex. Third, up to apical constriction located with electronic apex locator. Fourth, radiographic apex only reproducible point. Classification of electronic apex locator. First generation resistance based electronic apex locator, which were developed based on the resistance principle. They worked best in dry canal. However, the presence of pus and pulpal tissue, blood, and irrigants on this principle was root canal. Classification of apex locator, electronic apex locator. Electronic apex locator is the most optimal and accurate method to establish the root canal working length. What is the concept of electronic apex locator? The electronic apex locator is based on the working length is determined by comparing the electrical impedance of the periodontal membrane with that of the oral mucosa. This is done with the help of an electronic apex locator cord that has two ends. One end is termed as lip hook, that is kept in contact with the oral mucosa of the patient, while other end is termed as file holder, that is like probe, which is attached to an endodontic instrument, usually K-file or rotatory file. The attached file is slowly inserted into the root canal up to the estimated working length. When the endodontic file touches the soft tissue of the periodontal membrane, the electrical resistant gauges for both oral mucosa and periodontal ligament would have similar readings. By measuring the depth of the insertion of the endodontic file, one may determine the exact working length of the root canal. Classification of the electronic apex locator. First generation is resistance-based electronic apex locator. It is developed based on resistance principle. They worked in the best in dry canal. The presence of pus, pulpal tissue, blood, and irrigants lead to inaccurate readings. The first apex locator based on principle was root canal meter. Second generation is impedance based apex locator. Third generation is multiple frequency apex locator. This apex locator determines the canal terminus as difference between two impedance values at two different frequencies. Fourth generation is multiple frequency radio based apex locator that uses two wavelengths whose impedance could be compared as a ratio. These are superior to the other apex locator in the presence of fluid and electrolytes. The file starts to automatically rotate the moment the instrument is introduced into the canal. What is the limitation of electron apex locator? The accuracy of electron apex locator may be altered in cases with the following: open apex, calcified or blocked canals, excessive hemorrhage. Measurements get altered when the file contacts any metallic restoration. This is the first method of determining working length. Second method is radiographic method. Good quality preoperative radiographic and working length determination. X-ray should be taken using paralleling technique. We need some angled X-ray to separate superimposed object. Knowledge of average length of the tooth. Stable occlusal reference point in anterior teeth incisal edge, in posterior teeth cusp tooth. Silicon stopper on the file is to set to this reference point and extent of the file from bottom of the stopper to the tip of the instrument. These stopper also have an added advantage because they do not have to remove from the instrument during sterilization. This is Engel's radiographic technique for measuring working length. Clinical technique. We measure the tooth length. This length we reduce 1 mm to compensate for radiographic distortion. This length we called it as tentative working length, which is set on file using rubber stop. After access preparation, we place a file in the canal, expose the radiograph. Called it as working length radiograph or file in place radiograph. From that radiograph, we should measure the distance from the tip of the file and radiographic apex. If there is any discrepancy, that is added to this length. From that, if we reduce 0.5 mm, because that will give us total tooth length and working length is less that, so we reduce 0.5 mm and take it as working length. Vini recommendation considers various clinical scenarios such as vital pulp, apical periodontitis, periapical lesion. He said that if there is no bone desorption, it is safe to keep the working length 1 mm short of the radiograph apex. If there is any bony lesion, 1.5 mm reduce. If there is any large bony lesion or bone desorption, 2 mm short of the radiographic apex to prevent over-instrumentation and overfilling of the root canal. What are the flaws of radiographic working length technique? Neither the apical foramen nor the apical constriction can be seen in the X-ray. Lack of 3D information, highest possibility of dense bony structure. Engel's radiographic method of working length determination. First, diagnostic radiography used to estimate the working length of the tooth by measuring the tooth from a stable occlusal reference point till the radiographic apex. Subtract at least 1 mm from this length as minor constriction is always present short of the anatomic apex. Compensation for radiographic image distortion. This measurement is transferred to the diagnostic instrument with the silicone stop which is placed in the root canal and working length radiograph is taken. On the radiograph, measure the difference between the end of the instrument and radiographic apex of the root. Tip of the instrument end 0.5 mm to 1 mm from the radiographic apex. If short of the radiographic apex more than 1 mm, add this value to the earliest estimated length and adjust stopper on the diagnostic instrument accordingly. Retake the working length radiograph. If it is beyond the radiographic apex, reduce this value from the earlier estimate length and adjust stopper on the diagnostic instrument according to the retake of the working length radiograph. Cleaning and shaping, one of the most challenging and technically important aspects of the endodontic treatment. Earlier canal preparation or biomechanical chemomechanical preparation, controlled removal of dentine and root canals, content using root canal instruments and irrigants. Presently called it as cleaning and shaping. Shaping actually facilitates cleaning. Cleaning removal of the root canal contents. Shaping controlled removal of the dentine to achieve a uniform tapering homogeneous shape. It helps to achieve a proper shape to reduce an inert 3D filling that seals the root canal apically and laterally, thus prevent leakage. What are the objectives biologically? Shape object. We try to create a continuous tapering shape from canal, sufficient flare while maintaining the canal with anatomy. We try to keep the foramen as smallest, practically maintaining it in its original position. The final preparation should be an exact replica of the original canal configuration in shape, tapers and flow, only larger. Step in treatment. First LA is given. There is assess preparation, pulpectomy in case of pedo patient, then working length determination, then irrigation, then canal preparation. In canal preparation, rules for cleaning and shaping. Straight line assess. There is removal of caries, unspotted tooth structure, faulty restoration. Next is access to the pulp chamber and orifices. Third one is working length determination. Fourth one is constant irrigation using sodium hypochlorite and EDTA. Fifth one is working length should be maintained. Sixth one is we should always use instrument in sequence with periodic recapitulation. Seventh one is barbed broach to be used only in wide canals within winding and on insertion and rotation. Eighth one is reaming action. Ninth one is H-file in rasping action. 10th one is K-file, both reaming and rasping motion. First instrument that binds at the apex start the preparation and apex apically 3 to 4 mm to be enlarged to 3 to 4 sizes greater than the first instrument that binds. Do not force an instrument that binds. Discard deformed or strained instruments. Debris should not forced beyond the apex. Create continuously tapering the shape, keeping the apical constriction small while flaring the coronal and middle third. Techniques for cleaning and shaping. Apico-coronal approach. The working length is established. The full length of the canal is prepared from apical to coronal. In this method, there is Ingalls conventional, which is given in 1961, and step back technique. In conventional, which uses the larger instrument up to the working length, prepares the root canal to the smallest size and shape and tapers as a standardized instrument. It works best for straight canal. Step back technique. Apical preparation. First working length is determined. Then apical preparation start with first file that binds at working length. Apex enlarge at 3 times larger than the first file. Last file for the apical preparation is master apical file. If we select size 10 or 15 and find it very loose in the canal, then take larger file only when we feel resistance. We feel it is binding, then we should keep it as standard. That is master apical file. Conventional step back technique, that is telescopic technique. The canal is enlarged first in the apical third to at least number 25 or 30 instrument. Then each larger root canal instrument is used for shaping the middle third and corner third part of the root canal. Shaping and cleaning of the root canal begins on completion of the gross debridement and determination of the exact working length. The size 10K file is followed by 15K is inserted directly through the canal orifices to the desired length. K files are used in reaming motion against the walls of the root canal. The entire canal is then irrigated and all the solution and debris are aspirated out of the canal. Once the area of the apical foramen is clean, the apical third of the preparation is started. The apical third is serially enlarged to develop an apical stop of at least file 25. The next stage is step back preparation, which is achieved by increasing the size of the file and decreasing the length. That is by using size 30, 35, 40 and 45 file at 1, 2, 3, 4 mm short of the working length respectively to produce a coronal taper. To prepare the body of the canal, each larger file is inserted until it makes unforced contact with the wall of the canal. Then recapitulation should be done, which means returning to the smaller instrument from time to time before advancing to a large size help to prevent the packing of the intestine fillings and ensure patency of the root canal through apical foramen. Once the body of the canal preparation is complete, number 2, 3 gates Glidden drills are used to further funnel the preparation coronally. Circumferential filling using the master apical file can be used to smooth out and further refine the steps created by the step back technique. Next one is crown down technique, which is important. The concept of first instrumenting the coronal third of the root canal before apical shaping. In crown down technique, patency of the canal is first established with size 8 or 10K file. This procedure involves the preparation of the coronal third using H file of size 15, 20 or 25 to a working length depth of 18 to 16 mm or to the point where the file start binding. This is followed by flaring the coronal segment of the canal with number gates with the help of Gates Glidden drill number 2 and 3. Sometimes number 4 can be taken. The next phase involves apical instrumentation with small size 10K or 15K file followed by working length determination. A large file, that is number 60 is placed in the canal to the level of binding and the canal is instrumented using a watch winding motion until resistance is encountered. The procedure is repeated with smallest file until the working length is reached. Recapitulation with the size 10 or 15K file is in between. Canal should be irrigant with appropriate irrigants. The apical portion of the canal is now enlarged to the appropriate master apical file size, which would vary from canal to canal or tooth to tooth. Third one is a hybrid technique. It involves the combination of crown down technique and step back technique. First, achieving patency with the pre-carved number 10 or smaller K file, then 15, 20, 25 K file to the point of canal binding, then coronal pre-enlarging with gates lead and drill in the sequence of number 3 followed by 2, then number 1. Establishing the working length with size K15 file, placement of size 40 or smaller K file to the point of canal binding. In step back technique, enlarging the working length from size 15K to recommended master Pickel file size. Then canal preparation is done with the sequential use of progressively larger instrument. This step back procedure is performed until the middle third to obtain continuous stapling using canal preparation. We have completed this topic, which is cleaning and shaping. I hope you understand, but you also have to read it from book. And thank you.